University of York. This is the Research Room.
Hello.
Hello.
Welcome to the Research Room with me, Lucy Ather.
And me, Janine Healy.
And today on the Research Room, we're talking about the PERISCOPE project. So we've got Kulveer Mankia and Sam Brady with us. Welcome to the Research Room.
Hi, Barry.
Hello. Thank you for having us.
You're very welcome. I'm Sam. This is your second time in the Research Room, so
Can't
welcome
keep you
back.
away.
I know.
Hello. Thank you very much. Nice to be back.
So just to start us off, could you introduce yourselves for us?
Yeah, I'm Kulveer Mankia. I'm a consultant rheumatologist working at Leeds Hospitals and professor of rheumatology at the University of Leeds. And I am the co-chief investigator of the PERISCOPE clinical trial.
I'm Sam Brady. I am a trial manager based at the University of York, and I am the trial manager for PERISCOPE. And I've been on PERISCOPE since day dot. Since September
really great.
2022.
Oh, wow. Yeah, quite a while.
Yep.
From the very beginning. Great. Well, could you tell us what the long name of your trial is? So obviously PERISCOPE's the short name. What's the full title?
Well, there's a bit of a story to our
Oh,
acronym. So
Okay.
at stage one, our trial's actually called Scooby-Doo.
oh, really?
Scooby-Doo.
Yes, Scooby-Doo, which
Oh,
stood
wow.
for Stoppage or Continuation of Biologic Therapy During Orthopedic Operations.
Oh,
But due to copyright, I believe, is that right?
oh
Yeah.
really?
Oh, no.
We weren't allowed to call it Scooby-Doo.
Uh,
And I think that would have taken the title for the best title.
yeah. Oh, I like that
Oh,
one.
yeah.
Oh, so you had to change it to PERISCOPE.
Yeah.
Yes. And Janine is not going to like this
No.
acronym.
Oh, no.
I probably won't know.
So it stands for Perioperative Biologic DMARD Management, Stoppage or Continuation During Orthopedic Operations.
Right.
Right. Okay.
I heard that it said Peri. So it starts well.
Starts with a P.
Starts with a P. Yeah. Yeah.
Yeah, that's it, isn't it?
Yeah. So we have this little competition going where we rate everyone's trial acronyms.
And
So PERISCOPE.
You don't seem
yeah.
very impressed.
Well, I was impressed with the
We-
Scooby-Doo, but unfortunately that's not the
You
name.
can keep it
Yeah.
at Scooby-Doo.
No, that's cheating. We
That
have
is
to do
cheating.
PERISCOPE.
So,
Yeah, Scooby-Doo was a bit more fun.
say it again. So it's
Well, Peri was in that. Perioperative.
Perioperative Biologic DMARD Management, Stoppage or Continuation During Orthopedic Operations.
has it got any of the first letters in there, apart from the first one?
Yeah.
Of
Peri,
each.
P-E-R-I, is peri from perioperative.
Ah, okay.
And then the scope comes from the S from stoppage, the C and the O from continuation. The C from continuation, the O from orthopedic surgery, the P from orthopedics, and the E from orthopedics.
So you wanted to make...
Kulveer, who came up with this?
Was it
Who
you?
picked these letters
Who did
out?
pick these
Am I going
letters?
to insult you with...
You are, I think.
Oh, I'm so
Oh,
sorry.
was that you? Yeah. Well, we don't like it when the letter isn't the beginning of the word, do we? Because
Right.
I think P and E, you've just taken them from the middle.
To be fair to us, we sort of drained all our effort on Scooby-Doo.
Yeah.
But when that was turned down, it was a last-minute thing.
Yeah.
And we were we couldn't be bothered anymore.
Well, yeah, I don't blame you, really.
Oh.
It's your creative juices has all gone.
They've
That's
gone.
it.
Yeah, that's it.
Great.
You do. Maybe you get a bonus point for Scooby-Doo because I
Yeah.
like that. I like
Yeah,
that
okay.
one. Yeah.
So I'll let you rate it first then.
Out of 10 for Periscope. Ooh. Well, the word Periscope.
But it doesn't
quite a
mean
nice
what the
word.
trial is. So is
but
it, you know,
yeah,
is it,
yeah.
why a periscope? Is a periscope sort of like, you know, you're looking up.
Yes.
Yeah.
And it-
Finding the solution.
Yeah.
Emerging,
emerging from the
emerging
deep.
from the deep to find the solution.
Oh, okay. I like
Yeah.
that. Yeah. Okay. Yeah.
Quick
And
swaying
the
me a
peri,
bit.
because it's all about perioperative. So we thought
Okay.
having that in there.
Okay. Yeah.
And also, we're looking for like one of our outcomes is obviously we'll get into it later, but infections are like really hard
Mm.
to find
Ah.
sometimes. So it's like looking deep for
So
them.
you see there's a number of layers to this.
Yeah, you've
I'm
thought
seeing
about
the
this,
layers
haven't you?
now. Actually,
Yeah.
You know what? That's bumped up a
It
few
has a
points.
bit,
I think.
yeah, same for me. Yeah. Okay.
I think I will give you a 6.5.
Oh,
Yeah,
6.5.
0.5.
yeah.
What shall I give?
You be the friendly judge, like on Strictly. Go a bit higher.
I think I could, but it's
Just think of Scooby-Doo, though.
Yeah.
Oh, God, you've swayed me. All right, then you can have 7. Because of Scooby-Doo.
Yeah, because of Scooby-Doo.
I feel so sorry for you.
And you know,
And for our quick-wittedness there, for
yeah.
defending Periscope.
You defended that very well. You
did
made a very
actually,
good
yeah.
argument for
Yeah.
Periscope. So
Yeah.
you've done well there.
Yeah. Not many people have defended it.
No,
Yeah.
you defended that very well.
Not the first time we've had to defend it.
Yeah, I can see you've had practice.
Okay. So, in a nutshell, can you describe your project, what it's all about, everything to do with it?
Sure. So this is a trial addressing a very important clinical question for people with inflammatory joint problems who are on a certain type of treatment called biologic therapy. Just to give you a bit of background, biologic therapies have sort of revolutionized the way we treat inflammatory joint diseases like rheumatoid arthritis and ankylosing spondylitis because they're very effective. And they've been around for the past couple of decades, and the outcomes for people with these diseases have improved dramatically. Before they were around, many people, unfortunately, struggled to get improvement, and disability was quite commonplace. And that's changed because these therapies are very effective. But with that effectiveness, there are some challenges. They do increase the risk of infection.
Right.
So one issue sometimes is when patients who are on these treatments, something else happens, like they have an operation or they have a trauma. What do we do with these treatments? And we've never really known the answer for operations. And of course, patients with these conditions often do need operations, particularly orthopedic, bone and joint surgery. And it's always been a question as to whether we should stop these drugs when people have the surgery, or should we carry them on? And patients have always said that when they stop them, they don't much like it because the condition can flare up because they're not having a treatment that works for them. And that can cause all sorts of problems, like they don't recover as well, they're in pain, they need to have other painkillers, steroids. Not a very good time for them because they're having this surgery and they need to recover and recuperate, get better.
Yeah.
But no one's really had the confidence to say, actually just carry on these treatments.
Right. Okay.
Because there's this underlying intuitive concern that it may be increasing the risk of having an infection.
I see.
So we set out to do a randomised control trial. So it's the first randomised control trial to properly address this question. It was high on the research agenda because NIHR commissioned this trial as an area of high unmet need. And the studies led by myself and Hemant Pandit, who's a professor of orthopedic surgery in Leeds, also the director of our research institute in Leeds. And then we've had Sam, Catherine, Joy, very capable colleagues. And so we've all come together to deliver this study. And it's straightforward, it's very pragmatic. It's randomizing individuals to either continue their biologic therapy when they have an orthopedic surgery or stop it.
Right. Okay.
And in those that stop it, they will come off as per standard practice, have the surgery. When the surgery is finished and they've recovered, restart the drug. And in our intervention group, they will just carry on the treatment all the way through.
Right. Okay.
And we're going to compare how people do and see what the impact is on a multitude of factors: quality of life, their disease activity, how much other treatments they've needed, and of course, infections. And the other relevant point to mention is this sort of approach was done in the 90s for a drug called methotrexate, which is a very commonly used drug for rheumatoid arthritis, first-line treatment. And in the 90s, people didn't really know what they should be doing with methotrexate, whether they should be stopping it or continuing it. And a trial was done in the UK that answered that question. and it was beneficial to continue it and not stop it.
Right, okay.
Patients felt better continuing it. And the risk of infection actually didn't come out in the trial. It's something in people's minds that didn't actually come out when we looked at the trial data. And as a consequence of that trial, it's routine practice now just to continue methotrexate. So it's a big impact of that study that changed the way we do practice around surgery.
Yeah.
So we hope that we'll be able to achieve something similar now for biologic therapies, which are more effective and now increasingly used.
Yeah.
Right.
Great. So the inflammatory joint diseases, am I right in thinking that's different to the kind of osteoarthritis? It's more about your immune system causing that rather than your joints sort of wearing away.
Exactly right. Yeah. So that's these are autoimmune conditions.
Right.
So that's where your immune system, which is we all have to protect ourselves from bacteria, viruses, it becomes active and neutralizes these environmental threats. It goes wrong. So people call it friendly fire or misbehaving.
Right, yeah.
Friendly fire.
Or a misbehaving immune system.
Yeah.
It starts to become inappropriately active against our own body, our own tissues. And that can happen in multiple tissues. And there's multiple autoimmune diseases. Rheumatoid arthritis is one of the better known and most common. Affects about 1% of the population.
Okay.
And the immune system becomes inappropriately active against the joints and the tendons, causing inflammation. And the other rheumatological conditions, psoriatic arthritis, ankylosing spondylitis, are variants. They're a little bit different.
Okay.
And they can affect different joints. Ankylosing spondylitis affects the spine. Psoriatic arthritis can do as well, whereas rheumatoid arthritis mainly affects the small joints like hands and wrists and the feet.
And so does the treatment, the biologics, are they trying to stop the immune system, stop this kind of friendly fire?
Yes.
Stop that. So does that reduce your immune system a bit?
Yeah, that's right. They are doing that. So that if you look at what the immune system's doing in the joints in these conditions, it's causing an overactivation, a lot of inflammation. These immune cells are sort of in the joint and are active. They're alive.
Yeah.
And they're trying to neutralize a threat that isn't really there. So they're sort of behaving in a way that you might expect is normal if there was an infection there.
Yeah.
They're going to become active towards this infection and get rid of it. And to do that, they're going to wake up and start producing all these chemicals to kill. And it's these chemicals that they produce that make you feel ill when you have an infection. Give you a fever, make you feel tired.
Oh, right.
It's not so much the bacteria always, it's your own response.
That makes you feel ill.
Oh, right.
Going crazy trying to neutralize and get rid of the bacteria that makes you feel ill. And in the autoimmune conditions, the same sort of thing's happening, but inappropriately. There's no threat there.
Yeah.
Just your own body.
It's just gone haywire.
Just gone haywire.
Yeah.
And so these drugs block these chemicals that are being produced, and that downregulates the whole response. And as a consequence of that, you're right, that they do slightly increase the risk of you being susceptible to infections.
Right. And so that's why they would stop them when you have surgery, because you don't want your immune system to be sort of dampened.
Exactly. So on that basis, when we give these drugs to lots of people and they work very well, but we notice people that are on the drugs get a few more infections.
Yeah.
And we encourage vaccination and patients are careful. So on that basis, intuitively, we would worry that if you have a surgery, you would be at higher risk potentially of an infection.
Yeah.
But this is a theoretical concern.
Yeah. There's no evidence.
Without evidence. That's right. So this was around generating that evidence. It's a complex scenario because if your autoimmune condition is overactive, that itself increases your risk of an infection.
Yeah.
So you're always balancing things.
Yeah.
You're balancing the condition being overactive and not controlled, and that's not good in a multitude of different ways, versus controlling that, but then having this drug that could potentially increase your risk of infection.
Yeah.
So it's that balance and where you strike the balance.
Yeah. No, it's a really interesting question because I suppose on the one hand, you think, well, we don't want to kind of dampen down the immune system when you're having surgery. But then on the other hand, you might need the immune system to be dampened down a bit so you don't get these kind of flare-ups of the arthritis.
Yes. And it's a common, when you stop the drug, many people will experience flare-ups, and quite quickly often from stopping the drug. And in people our patients who have had a surgery that stopped the drug, they'll often say it was not a great experience, because just as the time they were trying to get better from the surgery, their condition flared up.
So
And
it's hard.
if you've had a hip or a knee replacement, you're encouraged to have physiotherapy and get up and get strong again, get active. And actually, if your underlying disease is now flaring up, that's hindering that.
That's the last thing you want.
That's the last thing you want. That disease becoming active again itself will be increasing your risk of getting an infection.
Yeah.
And the doctors treating you will think, we need to do something here because this person's disease is really active. So maybe we'll give some steroid, which works in the short term. And the steroid itself isn't great for your wound and isn't great for your immune system. So there's all these things.
So it's quite complicated.
Yes. And we learned from the methotrexate study that I mentioned that actually continuing the methotrexate, which is a drug, again, that works in these conditions, does appear to give people a better run after the surgery.
Right. Okay. So just on the kind of background to the trial then, you mentioned that arthritis is quite common, the rheumatoid arthritis. How many people does it affect?
It's about 1% of the population.
What's that really in figures? Sort of?
Now you're challenging me here. I think it's around 500,000.
Yeah.
I think it's
Roughly.
around 500,000, 450,000 to 500,000 people.
That's
in the
quite
UK.
a lot of people then.
A lot of people. More common in women.
Right.
Not completely understood why, but a lot of autoimmune diseases are more common in women. And average age of onset is in the 50s, early to mid 50s. So this is a condition that comes on in people who are active economically, socially, so working people. Many people have to change their lifestyle, stop work. Many people don't go back to work. It has a profound effect on people's life, engagement in social activity, ability to look after their families, look after themselves sometimes. And inherently, these are incurable conditions, rheumatoid and other autoimmune arthritides. They're incurable diseases in that once they come on, in the vast majority of people, they're going to need treatment in the long term. If we take those treatments away, it tends to reemerge.
Yeah, I see. So the treatment's very important then.
They're treatable in that you can bring the condition under control, but cure is a lot of people have tried for cures, and we do a lot of research trying to find cures, but it's been very, very difficult. That's why a lot of the focus of the research that we're doing in Leeds and my team are doing is around risk factors and very early disease, trying to intervene in a stage prior to the disease becoming fully established.
Right, yeah.
Kind of our approach that we take now for heart attacks and strokes. We don't wait for somebody with risk factors to get a heart attack and then treat the heart attack. We identify people with risk factors and try and modulate and reduce their risk.
Try and stop it before it starts.
And we're getting to that position now with autoimmune conditions.
Oh, great.
So the risk factors, are they genetic and things like that?
Genetics is important. There is, for rheumatoid arthritis, a particular gene that increases your risk. If you have a family member, we call them first degree relative, a parent or a child or a sibling, your risk is increased 2 to 3-fold. But it's not the only story, the full story. It's not the only risk factor. Most people that get rheumatoid arthritis don't have an affected family member, but it's one risk factor. Smoking is a big risk factor. It's the strongest environmental risk factor.
Oh, gosh.
And the genetics and the smoking interact to increase your risk. But what we're able to do now is identify people with very early symptoms.
I see. So you can help.
Because these conditions don't just come on overnight. Generally, people start to notice a change, tiredness, pain, stiffness. They feel something's going on.
Yeah.
So if you have someone with very early pain, tiredness, stiffness, and a positive blood test, you can predict with a high degree of accuracy that they're going to develop rheumatoid arthritis, which gives us the opportunity to intervene even earlier and potentially stop it coming on in its full form.
Mm-hmm. So with the surgery then, so this is all about kind of what we're going to do around surgery when these people need to have surgery. Is that joint replacements that people are having?
It's a variety of different operations. So in the PERISCOPE study, we've been deliberately broad, we want to include all sorts of orthopedic surgery because we recognise that patients on these drugs are not just having one type of surgery. To your point, it's not just one thing. It varies from your very so-called minor operations that might be removal of some metalwork from an old surgery. That might be straightening a toe or a finger, all the way through to more major surgery like a full hip replacement or a full knee replacement. So we've included that full range, and we've got a full mix of patients in the study right the way through all these types of surgery.
Great.
So Sam, how does the project work?
Yeah, so as Kulveer has mentioned, we're doing a randomised control trial, meaning that we flip a coin to decide whether they are allocated to the usual care arm, which is to stop the biologic, or to continue, which is our intervention. We are looking to recruit 296 patients, and what we're looking for in terms of our outcomes, so the question that we're wanting to answer is, does stopping or continuing the biologic, how does that affect a patient's quality of life? And we're measuring that by looking at something called the PROMIS 29, which is a patient-reported outcome.
I don't think I've heard of that questionnaire.
I haven't either, no.
So it's a patient-reported outcome, and it's got like 7 domains that we're asking patients around.
So domains?
Categories, I suppose, is a better word.
Okay.
And that's things around depression, anxiety, physical function, so how well they're able to move, pain, fatigue, how well they're sleeping, things like that, really. And then there's one question around the intensity of pain that patient's experiencing.
Okay.
And for PERISCOPE, we have quite an intense follow-up period right at the beginning. So once they've had their surgery, so they'll be asked questions at 2 weeks post-surgery, and that's around when they have, usually people that have orthopedic surgery will have a wound check to make sure that everything's kind of healing okay, and surgeons can sometimes spot early signs of infection if there is delayed wound healing. So they're asked these questions then. At 4 weeks, at 6 weeks, again, people are often seen in clinic, 12 weeks and up.
Oh, so quite soon afterwards, isn't it?
Yeah, and there's also one at 9 weeks. So there's 2, 4, 6, 9 and 12 weeks.
Oh, wow, so quite a lot of sort of follow-up appointments, I guess, for them.
Yeah, and we're most interested in those first 3 months. So those first 12 weeks, we do have follow-up appointments at 6 months and 12 months as well, but we're the most interested at over that 12-week period and the person's quality of life around there. And I think that's because, correct me if I'm wrong, Kulveer, but infections are usually presenting within that 3-month period after orthopedic surgery.
That's why.
Yes.
Yeah, so that's the main period you want to look at. And so you've got the questionnaires, and they're looking at quality of life, pain and function of the joint.
Yeah, that's kind of our primary interest. And then we're collecting lots of secondary outcomes, which includes our favourite kind of EQ5D.
Oh, yeah, we love that question.
We all use that. But there are also kind of disease-specific ones. So I think for, is it ankylosing or psoriatic, we do like joint count. Not we, I certainly don't, but our staff nurses and rheumatologists do joint counts. So literally counting people's joints and looking for inflammation. Again, Kulveer, please feel free to jump in. I'm not a rheumatologist. I'm just throwing that out there. So yeah, lots of secondary outcomes.
And so they're like kind of more physical assessments. So
some of the disease-specific ones are, and we also ask around questions like satisfaction with surgery. And questions. Lots of different things.
Yeah. So then you'll compare the answers to those questions
who continued or
the two
stopped.
groups. Yeah, and then see if there's a difference.
Yeah.
And on the point of the disease activity scores, so for each of the conditions, we have our favourite score or favourite tool that is basically asking a set of questions to somebody and maybe examining their joints or their spine, putting it into a calculator and giving us a number. And that tells you how you're doing.
Yeah.
And you get to recognise that this number, this is a bit high, or this is great, it's very low.
Yeah.
So each condition has their tool and their set of numbers that we get very used to assess how someone's doing on a treatment. And these are the disease-specific measures that we've put in.
I see.
So we want to see, using these tools that we're really used to using, if stopping the drug or continuing the drug has a positive or negative impact.
Yeah, yeah. And have you found it difficult at all with clinicians Because you're sort of asking them to not follow the guidance for this trial if they're in the intervention arm where they're continuing it. Has that been difficult at all? Because we've spoken about this before in previous trials where sometimes it can be quite difficult for clinicians
to put aside their preferences.
Yeah, exactly.
Good old equipoise.
You're referring specifically to surgeons, I think.
No, I would never say that.
No.
You've just
Okay,
really put
we do
Lucy on
all
the
the
spot
time.
there. I was going to say, if Hemant was here, he'd be saying exactly the
He'd
same.
say, he'd
Oh,
agree.
really?
To be fair, I think, yes, you're right, that not all clinicians have what we call equipoise, where they're on the fence and they don't mind. Some clinicians will have a predetermined view clinically that they're on one side or the other. That makes it difficult for them to participate.
Yeah.
So I'm not a surgeon, I'm a rheumatologist.
Yeah, you can tell.
But to
just reiterating that
have
point
a lot
before
of
he says this.
surgical colleagues and friends, and I do and fully understand their position, because when you're doing something to a patient, you're intervening. If something goes wrong, that's quite a big responsibility.
Yeah, definitely.
There are also registries that collect data like that on complications. So I completely understand that position.
It makes sense, doesn't it? Yeah.
But it's great when you have surgical colleagues that are very pro-research, because that's how things move forward.
Yeah,
and
definitely.
sometimes there can be a lack of robust evidence in certain areas of surgery because trials have not been able to be done, get off the ground for these reasons. Unfortunately, we have a lot of surgeons around the UK that have taken part and really gone for it and have been very happy and proactive.
So you mentioned you're recruiting from all over. Is it all over the UK?
Yes, we've got a really good geographic spread. We've got,
Great.
I think we've opened 25 sites.
Oh, wow.
We've got 19 that are, because they still recruiting. We have kind of officially finished recruitment.
Oh, great.
Oh, right.
So have you hit your target?
Not quite. So we need 296 and we're at 269.
Oh, okay.
Oh, it's flipped around a bit.
Yeah. But Leeds have got a couple more
We misread
in the
it.
pipeline.
Is that your excuse? I like it.
Leeds have got a couple more, so that gets us over the 270 mark.
Oh,
But
okay.
we've been talking to the statisticians.
Yeah.
And the magic 90%, can we be 90% certain that our result is not down to chance?
Yeah.
The finding we find between the two groups. And we are pretty much there.
Oh, good.
With regards to the magic 90%.
Yeah.
So we just need to keep on top of following patients up. But we've got really high retention rates.
That's really good.
That's
in
good,
Periscope.
isn't it?
So I think it's around 88%.
that's
When you
across
say
the time
retention
points.
rate, you mean people staying in the study?
Yeah, sticking with us. So it's around 88%, which is really high.
That's really high because, we know we've talked about it before on the podcast that it's can be quite a challenge keeping people in the trial and keeping them engaged and doing all the questionnaires and follow-ups.
So
But I think it's handy that a lot of the questionnaires are quite soon after they've entered the trial,
Yeah, I mean, we do the questionnaires at 4 and 9 weeks. We do that. We send those out post or do them over the phone or do them online at 4 and 9 weeks. But they are seeing clinicians at 2, 6 and 12 to align with kind of normal clinic appointments. But I think patients are also reassured by the fact that they're getting kind of more intense follow-up than perhaps they might receive otherwise by being part of the trial.
Yeah, it is good that, isn't it? You get more attention, is that the right word? If you're part of a trial.
But on the flip side to that, you think, well, if I've just had a knee replacement and I've got to get, to Leeds, and we've got one centre, the Royal Orthopedic, where they take patients from all over the place. It might actually be quite difficult for those patients to be able to attend if they've had a knee or a hip replacement and get back to hospital within 2 weeks. So we are, trying to be pragmatic in that we will follow up people. Nurses will give them a call to try and collect the questionnaires over the phone and things. Not all patients will be able to make it back to hospital for some of those appointments.
Yeah. So even though you haven't quite met your target, the statisticians have said the results will still be fine.
Yes. Yeah, we'll still be confident with the result that we find between groups.
Brilliant.
When you say you didn't meet your target, is that one of the reasons for that is that you ran out of time? I don't understand why. if you come in saying now, well, we nearly got our target. Well, why didn't you get the full target? I don't understand. What are the reasons why?
So it could be for a factor of reasons. It might be that, we've been working with sites for a long time. They've always had kind of the end of November 2025 in their sites and are kind of winding down. Sites get fatigue if they've been recruiting for a long time. So they'll just sort of tail off. Often, I think particularly for Leeds are our highest recruiter by quite some way. Hundreds of patients have come from Leeds. You're seeing less of them now because they're all in the trial already. And you always think, it doesn't matter what trial you're doing, I think it would be fair to say, and stats would tell you the same as well. It's like you think there are lots of these patients out there, more than there probably are. So you're using kind of national statistics to estimate sample sizes, the number of people that you want in your trial. But actually, when it comes to actually opening centres and finding these patients, there aren't as many as perhaps we thought. So we've had some centres open and be open for a really long time and put a lot of hard work into trying to find these patients. They're just not there. So sometimes this is why we come just a little bit short. Also, time. We might be running out of money. The funder won't let us carry on to get that extra 30. But we're there or thereabouts.
I think agree, as Sam says, there's a multitude of factors, but that affect recruitment that you can't always envisage or account for when you're planning these things. Junior doctor strikes was one of them. We've had with the surgeons, affecting the surgeons quite a bit, to clinics being cancelled for elective surgery, which affects patients coming through and being identified. Maybe, alongside that, staff being redeployed to other areas, all sorts of things.
Winter pressures now, I guess, as well.
Pressures.
But I suppose for you, it's fine because you're okay
We're
with
always
it.
there.
You're there? Yeah.
But to be fair, I mean, we have been really lucky with Periscope, haven't we? Because we haven't had any major headaches. Recruitment has been fairly steady all along. We've had pretty good engagement with most of the sites. So whereas most sites, most trial teams will be talking about problems and things like that. We've been really lucky that
that's really good to hear.
Steady away, really.
Agree. And you get some really, there's challenges, but you get some nice surprises as well in that some centres just really engage with it.
We've had just a couple, run with it. Just run with it.
They haven't necessarily been investigators on the study, but they were approached and they really like it. They feel that their patients would really benefit from it, and they end up really taking a strong part in the trial that we wouldn't have predicted necessarily. So that's one of the advantages, I think, of going broad. You don't leave people out, but also you find sort of new friends, new collaborators.
That's lovely.
That's we could put that. Strapline. I found new friends doing the Periscope trial.
And are you doing any qualitative work on the trial? Because I imagine that would be quite interesting to see what the patient's views are alongside the kind of numbers and the measurements.
Yeah, so we do have a process evaluation that's going alongside. So we're interviewing patients and also rheumatologists and orthopedic surgeons. So patient side of it's kind of done. And similarly with some clinicians, patients think that continuing is normal. That normal practice, and stopping is different. And I guess that's for people that have perhaps not had previous surgery. A lot of our patients have had surgery previously, so they kind of know what standard practice is. But I think anecdotally, obviously, that the paper is written and about to be submitted, so I'm not going to give away any results here. And I think we would probably have guessed this, but patients would rather continue because it means they don't get disease flares. And infections in orthopedic surgery are around 1%, so they're quite rare. So people that have had surgery previously haven't experienced a surgical site infection, and obviously they can be devastating. So thankfully they are rare, but a lot of people will have experienced obviously flares up of their disease, so they would rather continue on that basis. So that's quite interesting.
Because I imagine for a patient, even if the results sort of say, if you continue the biologics, you might take longer to heal. But if they're in less pain, they might prefer that anyway. So it'd be a really interesting element to the study, I think.
So watch this space for that paper, and then the clinician ones I think are a little bit more controversial. So that won't be published until the main trial paper is out. So I think there's been kind of a lot of debate around, clinician preference, shall we say, and what the right thing is to do. Because I think, all of the surgeon's stats are available in the public domain. So any one of us could go and look that up. Surgical site infection, could result in an amputation, for example. So, they can be really severe. So I think there's quite a lot of debate in those in those interviews. So watch this space, but that'll be later down the line for that one.
And another aspect to it that probably we don't think about as much is the logistics around stopping treatment, restarting treatment, and how that can affect people. Sometimes someone may stop a treatment and then their surgery's cancelled.
Oh, yeah.
And they've gone through a period of coming off treatment, maybe had a flare, restarted treatment, and they're going to have to stop again. There's a lot of letters being written between surgery and rheumatology about what should be done with these drugs.
Yeah.
A lot of calls from pre-op nurses around what they should be doing, anaesthetists unsure about what they should be doing.
Yeah.
So there's a whole load of work there and logistical challenge around managing therapies perioperatively. Now imagine if that's not required and you simply say, get on with it and just keep going.
Because I think the other side to it, if I'm right, Kulveer, is that sometimes once they've stopped their medication, going back on it, that the medication can become less effective for managing their inflammatory arthritis as well. So there's that side of it as well.
Yeah, we're looking at that. We're looking at that at the moment to see, because anecdotally, some people, when they've been off the treatment for a while, when they restart, it may not work as well as when they're on it before. It's not a majority. It'll be a minority, but we're doing some work in Leeds to understand the proportions.
Yeah.
But it is a factor. We do see that sometimes.
Yeah. Oh, yeah. No, that'd be interesting to look at. Great. So what's next for the project? I suppose just finishing up your follow-ups.
Yeah. So we've built in a period now for people to kind of finish having the surgery. So obviously there's a waiting times all around the country. So that's one thing about the trial, trying to manage that to make sure that we can still finish on time. We should finish our follow-up in around 15 months' time or so. And then, I'll be crunching the numbers and getting the paper out there. Really. So just our focus really is just keeping on top of follow-ups and making sure that we're getting good engagement throughout.
Yeah. When do you say it should be finished then? Your results published, rather?
Around October, November 2027. So it's still a way off. Obviously, these things take a while.
They do.
Yeah. Because you've got the yearly follow-ups.
Yeah.
So,
But I'm sure both yourself and Hemant will be honoured to be writing the paper and just slot the stats bit and hand it over to you to write the discussion in the meantime. So it'll be good to go pretty quick off the press, I reckon.
Well, we're hoping that the what we find to be quite impactful.
Yes.
Have a direct change on management. The guidelines at the moment are guidelines that are out there, and it's acknowledged that there isn't really good, robust evidence behind them.
Yeah.
So I think that certainly the rheumatological societies and the orthopedic societies to be very receptive to new data like this that's come out of a randomised controlled trial.
So after you publish a paper, what happens then? If you find out that you really do need to carry on with these the drugs, how long will it take to get that into make an impact, make a difference, really?
So we even prior to the formal publication, we'll present the results at conferences, and we'll present them at rheumatology conferences, the British Society of Rheumatology, which is our UK society, EULAR, which is our European society, and at the American College as well. We have a collaborator actually in the US who's collaborated with us on this project, who's leading the area from New York in the US, and she's done similar work, even though they haven't done a randomised trial, and they're very keen to hear the outcome. And that will get the message out in terms of what the data is showing. And then it's a case of engaging with the professional societies, potentially setting up a task force around the area with a view to integrating into guidelines.
Oh, I see.
Yeah, no, it sounds like it'll be really impactful. Either way, really, if you've got the evidence, either changing the guidance or just backing up the guidance and kind of making it known that the guidance is supported by evidence. Yeah. Oh, well. we'll look out for the paper, won't we? And then maybe when you have results, you could come back and share them with us on the research room.
Yeah,
absolutely.
Very happy to.
Great. Well, I think now we've got some random research questions for you that we're going to pull out of the hat.
The summer hat.
The famous hat,
The
that being
famous
the summer hat, that should be a winter hat, as you quite rightly think. I'll let you pull it out first. Go on then.
I'll do the first one. If your research had a theme song, what would it be?
That's a really hard question.
What do we think? Something to do with arthritis? What song is about?
Or infection.
Is there a song about surgery?
Bones, joints.
Yeah. Them bones. What's
Them
that
bones.
song?
Them bones.
Yeah.
It's like that skeleton song.
Yeah. That's like my arm bones connected
Yeah.
to my
shoulder bone. That one, yeah.
Yeah. It would have been the Scooby-Doo theme, wouldn't it?
Oh,
absolutely.
yes.
Yes, it
That's
would have been.
But you could have,
We could still have that.
well, you'd hate
we can have
copyright
that.
problems again, won't you? But never mind. It's only
Never mind. We'll
We'll have
unofficially.
Scooby with an eye. We'll just pinch a letter from a different part of a
Yeah,
word.
You remember the
Exactly.
Scooby-Doo theme song?
Yeah.
Go on.
Dooby dooby doo.
Oh, yeah.
Where are you?
Yeah, that's it.
Yeah. I
Oh,
like
yeah.
it. I won't sing the whole thing, but I
No.
do know it. Okay. That's a good one. I like it.
Yeah, that's a good one. Oh, I'm going to pull another one out. Oh, what's your favourite type of chart or graph and why?
I quite like the Periscope recruitment graph, to be honest.
Oh, you
That's
must.
brilliant.
Yeah, you must be happy
So-
with that. Your retention graph must be
Said
looking
like
great.
a true trial manager.
Yeah, honestly. Some of them you see are not good, but Periscope,
Yeah, I bet.
it's a good graph.
Okay.
Yeah.
Same.
Same.
Yeah.
Absolutely.
Okay, that's a good
I'm
one.
very
That's a
proud of
good
your
one.
recruitment graphs.
You should be.
Honestly, we have the shortest trial management group meetings, trial steering committee meetings, data monitoring, because everything's just like,
Oh, I bet.
yeah, it's going in the right direction.
Everything
It's
is
keeping
going
people in.
well.
Lovely
Happy
stuff.
people.
What's one thing you wish you had more time to spend on? So that can either be sort of in the trial or just in your life.
I think we'll stick to the trial.
Yeah.
Don't want to get too deep. Well, I think probably there's a couple of satisfying things. I like speaking to the investigators at the different sites. I think we get quite a bit from that.
Yeah.
We've tried to do a bit more with that, actually. That we in terms of supporting sites, hearing from people that are actually doing the work on the ground, the research nurses, the investigators, and actually getting people engaged, returning to people who were maybe not so sure about the study. Everyone's busy and people have a number of trials that are on their portfolio, and sort of there's a bit of going through the motions in these things. If you're able to spend a bit more time with the team doing it, explain the value of it, explain our experience in Leeds, how we've done troubleshooting, and some people really take that on, and you go back and actually they're having a different experience. That's quite rewarding. The other aspect, I think, the PPI work. So hearing from the patients who have been people that have undergone surgery and saying, oh, this sounds something I would have engaged with, or if I was to have a further operation, this sounds great. It just sort of validates what you're doing.
Yeah, that's good.
And a lot of the PPI meetings have really brought out some points that we would have never thought of. Around challenges with getting engagement or recruitment or little problems that come up, and you're sort of thinking in your area on your track, and then you'll have someone say, why don't you just do this, or why don't you just present it in this way, or you think, actually we would have never thought of that. So I think if you had more time, it would be spent in those areas. I think pretty rewarding, quite valuable actually in adding dimensions to what we're doing with the trial.
Yeah, it's always good to hear from other people, isn't it? Now their take on things that you're doing.
Yeah, definitely.
Oh, yeah.
Sam? You know me, I'm always a fan of patient and public involvement in trials and research. So, but yeah, they're such a lovely group to work with, and they're kind of really forthright as well in their views, and they will just kind of, it doesn't matter how long we've been working with them or, what point in the trial either, because sometimes there's lots to talk about and sometimes there isn't quite so much to talk about. But the idea is, we're so tunnel visioned with the end goal sometimes that we don't think about wider context. And I think even from our last meeting, we were talking about how do we keep people in the study with us so we can keep the magic 90%. They're like, just give them a pat on the back, just say thank you, send them an e-card at Christmas. So that's what we're doing. It's just like, it might be something really simple, but we're just so tunnel vision sometimes that we just don't think.
Yeah.
So we send out a newsletter to try and help, just kind of touch base with them, because they have this really intense 12-week follow-up period, and then they don't hear anything from us for months. So it's just an opportunity to kind of say, hi, you are still valuable to us, and we haven't forgotten about you, kind of thing.
And people, when they're involved in trials, it's nice to have that connection as well, isn't it?
Yeah.
What advice would you give to someone starting a similar project?
Oh, that's really hard.
It's not as fun as thinking of a song, is it?
No, but I guess things you've learned, things like that.
I mean, like I say, we are really lucky because we have got a brilliant team. Both Kulveer and Hemant are really engaged. We meet regularly. They're always available on email. But I think that makes my job a lot easier, knowing that, we've got these guys to call on if we need anything. And it also, we got out the starting blocks quite quickly. So the grant application was really well written. So from my job as a trial manager, that makes it a lot easier. A lot of things were ironed out at stage 2 of the grant application process. So there were a few things that we needed to talk through and kind of iron out. But in the main, the bulk of it was there. So writing the protocol and getting everything ready was really quite easy for me. So I think for me, it's the collaboration and the relationship that you can build with your chief investigator, because it does make a massive difference to the project. And I'm not just saying that because Kulveer is here. I know my
3
colleague.
years and I've never heard anything like this.
It's recorded as well, so you
can
keep playing it back to yourself.
I know sometimes they see like a bit of like a grumpy Sam sometimes, because Hemant, bless him, would like to randomise joints, in which case we'd have probably hit our recruitment target many moons ago. But I'm just like, no, Hemant, we can't do that. So sometimes I'm a no person. So sometimes you don't get to say, actually, do you know what? It's been great working with you guys. They're a great bunch to work with, aren't they? So it makes our job easier.
Yeah, I have to say likewise.
That's only because I put him on the spot.
Not at all. From our side as well, we're in a great place in that we've got Sam, Katie, Gareth, the team, who are always on the ball, always know what's going on. Everything seems to be under control all the time. But I think as a team, I think what does help is that we're quite flexible. We all work well with each other. No one's sort of afraid of contacting anyone at any point. No one's afraid of mucking in to get things done. We all are sharing the same vision. Corny things, but that's true. We're all just sort of mucking in to try and get to that one place. I think advising someone on a big grant, a big trial like this, it needs sustained energy over a long period. And Hemant, my co-chief investigator, is brilliant at this. He's very enthusiastic, very energetic. We kind of try and bounce off each other. So if you've got a team, it's difficult to have one person taking on everything. Because there's going to be ups and downs. There's going to be periods where you think, this just isn't, why are we behind on recruitment? Why are we running through a patch where we can't engage where we want to? And you sort of bounce off each other to navigate through that. So be prepared to roll up your sleeves, work with the team, pitch in areas you didn't think you might have to pitch in, and most importantly, keep going, really. Just keep pushing through. But a lot of what's fun about it is encountering these issues that you wouldn't have thought of, and actually solutions coming out of areas you wouldn't have thought of. We talked about the patients and the advice you get given and other investigators coming on board. And just as you might have the challenges, you also get these moments where you think, oh, actually this, we're moving forward in an area we wouldn't thought, by a route we wouldn't have thought of before. So my take on it.
That's great.
It's brilliant. Really celebrate your successes.
Definitely.
Absolutely.
Which emoji best represents your research? Is there a periscope emoji? A little submarine, maybe?
Yeah, but that's you can't have a little periscope.
Why not?
Yeah, we suppose you could, yeah.
Or a joint. There must be a joint. But then you're sort of all sorts of different joints, aren't you? So you can
can't
just
have
have
any
like
old
a
joint.
Yeah,
hand.
it's like the arm one.
Yeah. But
We've probably gone through a lot of the emojis at different times, just thinking of them.
Yeah.
Stressed face.
Yeah.
You don't
Happy
smiley face.
You don't want to stress
Few
face
kind
as
of
your
the sweat.
emoji.
There's got to be. Is there a surgeon emoji out?
There might be with
Like
like a mask on.
Yeah, that's what I'm thinking.
Yeah, I think there might be.
Could have a periscope with a mask on.
Yeah.
Yeah.
Yes.
That's right.
Or in fact, actually, Hemant likes to send the
prayer one.
the prayer
Oh,
thank you one a lot.
okay.
So
Yeah.
so yeah,
Oh, that's a
Hemant
nice
sends a lot of
Yes.
thanks out.
Because
so.
that's like, thank you.
Yeah.
Yeah.
Yeah,
Oh,
okay.
Yeah, I like that one.
With a periscope on the top of it. Why I wanted to put after completely dismissing the periscope, I don't know why I
Yeah,
want to
you
put
love
it
the
on.
periscope now.
Yeah, love it now.
It's such a good trial. That's why.
Oh, it's a brilliant trial.
It is.
Yeah, it is. And yeah, that was really interesting. Thank you so much for coming in and telling us all about the trial. And really nice to hear that it's all going really well, because sometimes we hear about kind of challenges and things, but it seems like, yeah,
It's unusual.
been good.
It
It is
unusual.
a bit unusual,
Yeah.
isn't it?
Yeah, because it's the first trial I've set up from scratch, and I've always said I'm missing something. Like
Yeah.
definitely missing
Problems.
something because
Yeah.
because we just haven't had that.
Yeah, it's rare to have
yeah.
such a nice, smooth journey. So that's great.
I hope it carries on being smooth and
Yeah,
gets out there into the world.
yeah, definitely. Yeah, so thank you so much. We'll put some information in the episode description for people to find and learn a bit more about the trial. Yeah, and we'll look forward to the papers coming out soon.
Definitely.
Yeah. So thank you very
Thanks
much.
for having us.
Yeah, thank
No,
you.
thank you very
Oh,
much.
you're very welcome. Thanks. Bye.
Bye-bye.
Thank you.
Don't forget to like and follow The Research Room wherever you get your podcasts. And if you'd like to leave us a review, that really helps other people find the podcast.
Does it?
It does, yeah.